I'm really glad the election's over, though.
All right, now we're recording. And so are you able to see the slide that says November 8th? Somebody tell me yay or nay.
Yes.
Okay, perfect. All right, so once we've identified SVT, and y'all should be very well versed in the identification of SVT, the first thing we've got to do is not, first of all, worry about the treatment, but worry about, is our patient stable or unstable? Is our patient symptomatic or non-symptomatic? And again, as we're going through here, somebody unmute yourself and just jump in and tell me what are some of the things that you would look that would tell you that your patient is symptomatic.
Hypotension.
Hypotension. So we get a drop in a blood pressure. Now, Yusuf, let's build on that just a little bit. Let's say that the normal blood pressure that we say for everybody is 120/80, but let's say that this patient's blood pressure is 106/78. Is that low enough for you?
No. I think it would be like hypotension accompanied with like pale cool diaphoretic skin, or altered mental status.
All right. So the most important word that Yusuf said in that sentence was accompanied. Accompanied. We don't just look at a vital sign and immediately click off a box that says, now we can give drugs or we can give electricity. So we're going to look at our vital signs and we're going to take that in conjunction with how our patient is presenting. And so you did a really good job in there of saying, okay, here's hypotension as evidenced by low blood pressure. Obviously, our heart rate is already going to be fast, so we can technically go ahead and even say that our patient is in what phase of shock when we're looking at this. Compensated, decompensated, or
decompensated, sir.
Yeah, isn't decompensated. All right. And again, that comes about as a result, not just because of the rapid heart rate, but because of looking at the whole picture. So I want you guys to begin thinking of yourselves as artists, and you're going to, if you're coming into the hospital, you're going to paint them a picture that says,
Dr. Young.
Yeah.
Richard is trying to get in. He says he needs you to let him in.
Yeah, I just let him and a couple others in. Thank you. So again, if there's a problem, let me know. Don't hesitate. Thank you, Mark. So again, we want to paint the picture of when we get to the hospital, especially if your patient has completely recovered and they're pink, warm, dry, with a heart rate of 80 and a blood pressure of 130/78. You need to be able to paint that picture of saying, okay, this is what I saw as far as my assessment goes. And I'm huge on assessment because that's one thing that we're probably weakest in within EMS. Now, just like I said, some of the signs and symptoms that we're going to say, and Yusuf nailed on this pretty good, are going to be hypotension, low blood pressure, as well as the signs and symptoms of hypotension. What will be one of the earliest signs of hypotension?
Dehydration.
That can cause hypotension, but we're talking about specifically within the realm of SVT. So what would be one of the things that you would see, or one of the things your patient would report to you as
syncope?
far as, say it again?
Syncope?
Even before that?
Dizziness.
Even before that?
Anxiety and restlessness.
Perfect. Anxiety, restlessness, fear, and those are going to be the earliest signs. And how do we know that these are early signs of hypotension and not just the fear of the unknown? Well, we take the other vital signs that we're going to find on our patient and we're going to put them together. We already got a heart rate that's probably up around 150, so that's totally abnormal. We've got a blood pressure that is coming down, that is following. And if a patient is saying, I don't know what's wrong, there's something wrong, I feel like I'm going to die, that right there in and of itself, with those three things, is enough information to tell you that my patient is unstable. Now, again, as we'll talk about in the treatment here in just a minute, you've got three options that you can go to. Because your patient is unstable does not mean we necessarily go straight to the nuclear option. Just like when we're assessing our patient, we have different degrees of assessment. Even if your patient is unstable, we have different degrees of instability. And so I would caution you to not go directly to electricity if your patient's really only complaints are anxiety, low blood pressure, and that SVT that's going on. You would be perfectly justified to start all the way at the beginning with vagal maneuvers and then quickly work your way up. However, if your patient is beginning to show some pale skin, diaphoresis, maybe an altered mental status now, then you could indeed go directly to electricity and be perfectly okay. Again, with some of the signs and symptoms you're going to see on these patients, that they'll often have shortness of breath. That is a very, very common one. They will just say, my heart is beating so fast, I can't catch my breath. Now, let me ask you, from a pathophysiological perspective, why is it that they're having dyspnea? What's going on there that would cause them to have shortness of breath?
Probably like the chest pain accompanied with SVT, maybe.
Tell me more. Now you're on the right track.
So like oftentimes people will complain of like tightness in their chest or pressure, and the anxiety just kind of makes it a little difficult for them to breathe properly.
Okay, let's build off of what Yusef said, because he's on the right track there. Remember, we've got this really rapid heart rate, complaining of this discomfort in their chest, but quite often people will say, I just can't catch my breath. Based off what he said, what would be some additional information as to why they're not able to breathe well?
Is it because like the heart rate's so fast, like the demands for oxygen are like can't be matched with the if it was just like a normal or slow breathing rate? So
Perfect. Those of you, the two of you are perfect with your answers together. The heart rate is so very fast that we're, for all means and purposes, knocking down our preload to probably about 20%. As a result of that, now what happens is that the heart can't pump out what the heart doesn't have. And therefore, our patient is now going to begin to become dyspneic. They're going to have shortness of breath, again, primarily because they don't have enough air to be able to move around. And so that's really critical thing to kind of keep into mind there. Ultimately, we wind up with end-stage organ failure if we don't address this patient, and they can very quickly go into shock and into cardiac arrest. Does somebody have a question? Okay, maybe not. All right. So moving on. If your patient is unstable, and if they are really unstable, which, you know, one of the things that we have is it's half joke, half truth, is that if you look at your patient and you think, well, this patient's probably not going to mind me giving them some electricity, they're unstable enough to go directly to synchronized cardioversion. We want to go farther than that, and we want to look at our patient and we say, our patient is going to die if I don't do the most dramatic, most drastic treatment for this patient right away. Now, here's the thing to remember. Huge difference between synchronized cardioversion and defibrillation. So, Mark, tell me what is one of the differences between synchronized cardioversion and defibrillation? And if you're talking, you'll need to unmute. Okay, not sure where Mark is. Anybody, what's the big difference between synchronized cardioversion and defibrillation?
Defib is a lot more electricity, and it's what we'd use for somebody that's in like a cardiac arrest.
That's one big reason, or one big difference. Yeah, so we're going to use more electricity for defibrillation than we will for synchronized cardioversion. And you will often hear me say,
It's also,
I'm sorry, go ahead.
sorry, I'm sorry, it's also not like that synchronized where it like synchronizes up with the electrical capture.
Yeah, and this is one of the things, and I'm very, very happy to hear that you guys are working with the monitors in the lab, the iSimulates. Here's one of the keys, guys, is I see this on a regular basis, and I'm not entirely sure why this is over my years of teaching, is that sometimes new medic students, especially once they're into the second and even part of the third semesters, they still struggle with what buttons to push on the monitor. You got to get familiar with the monitor, especially as part of the delivery of electricity, so that you know that monitor like you do the back of your hand. So two things that we see here, like Kira says, number one, we're going to use more electricity in defibrillation than we do cardioversion. And as I said, you'll often hear me refer to it as just simply cardioversion. I'm meaning synchronized cardioversion. With synchronized cardioversion, we're going to deliver that impulse at the height of the QRS. So, Ahmad, why would we want that to come at the QRS, the top of the QRS, and not anywhere else during the depolarization process of the heart?
That doesn't cause the RMT phenomenon.
Perfect, sir. Very, very good. Yeah. As you recall, if we get a depolarization that occurs during the relative refractory period, the second half of the T wave, we can put our patient into ventricular fibrillation. Now, the chances are that if you were to do that when you're doing cardioversion, that you would just simply turn your synchronization button off. You could defibrillate your patient, and your patient would resume. However, you got to understand, if we're going to go the route of cardioversion for our patient, we've already determined that our patient is going to have a fairly significant degree of instability. And as such, we definitely don't want to put them into a state of death, which is actually what ventricular fibrillation is, because now they may not respond back to that. So again, just kind of doing a little bit of a review. Synchronized cardioversion is delivered at the peak of your QRS. One of the reasons is that is far away from the T wave. So we don't want that R on T, as Ahmad correctly shared with us a while ago. In doing so, you will now begin to see little markers that will come up here at the top of your QRS. If for whatever reason, and you could, depending upon what lead you're monitoring in, you could have an inverted QRS, and if that's the fact, then it'll occur down at the bottom. But again, the thing that we're looking for is we don't want to push any buttons until we see that synchronization marker at the top of the QRS. Now, again, just kind of to reiterate what Ahmad said, if we don't, then we're going to have an ROT, and now this can put our patient into ventricular fibrillation. For synchronized cardioversion, has anybody looked at the information? And for your algorithms, I would encourage you to become best friends with your ACLS guide. So I want you to make sure that you're starting to memorize those algorithms, in particular, starting with this one on tachycardia. What is the dosage that we would want to use for synchronized cardioversion of our adult patient?
100 joules.
Yeah, good, Mark. So we would typically start at about 100 joules. Now, again, like we've talked about with pain management, size matters in here. You got a small person, 100 is probably where you're going to work. You got a person that's got a lot of, as I like to say, redundant tissue on their chest. And you may even consider to go up to 120 or 125, depending upon the patient's size. Again, here's the key thing to remember. Your protocols are not written in stone, brought down by Moses from Mount Sinai. You can vary from them within a certain parameter. But here's the thing to remember, ladies and gentlemen, if you vary from them, you've got to be able to articulate the why. Why did I do this? So if a physician says treatment for SVT is 100 joules, why did you start with 125? And you can say, well, look at the patient. He's 350 pounds. 100 joules is probably not going to be able to touch him. Can't promise you that all of the people that you talk to will be gracious and accept that without being a jerk. But if it were to get kicked up and accelerated either into like a disciplinary hearing or potentially, heaven forbid, into a lawsuit, you've got good protection that will keep you from ever having to have a penalty or to pay out for that. Now, in children, the first dose is 1/2 to 1 joule per kilogram. Again, this comes into play here as to showing out, that the size does matter. Now, we can double this up to 2 joules if we move on into subsequent attempts. Here's the thing I want you to remember as we're moving through. I'm a firm believer in the use of checklists and memory aids, especially when we're dealing with low frequency, high acuity types of emergencies. You and I are not going to see a lot of pediatric patients who are in SVT. In my career, I can think maybe 1 or 2. And so keep something like that with you so that you can refer to that. When you go through 305, I will allow you to refer to study guides, not study guides, but memory aids and reference guides to a certain degree on certain extents, and this would definitely be one of them. I would not expect you to remember this. So what do we do as far as starting with our treatment of SVT? Well, the first thing that we can do is that we can start with what's known as carotid massage. These all fall under the umbrella of vagal maneuvers or Valsalvas. And what we're trying to do is that we're trying to increase the pressure so that the pressure affects the vagus nerve. Now, as you remember very well, if we put pressure on the vagus nerve and everything works out okay, that's going to put the brakes on the heart. So now, Austin, as we look at this, and we'll talk more about carotid massage, basically you're just pushing in on the carotid artery. How in the world would that put pressure on the vagus nerve, which is running through the heart, which could be as much as 10 to 12 inches away? All right, Austin, if you're talking, you're muted.
The vagus nerve runs down.
So it does run down through the neck. It does not run alongside either one of the carotid arteries. So here's what happens. As you can see over here in the first graphic, we've got this person that's putting pressure, and carotid massage is kind of a misnomer. We don't rub it. We just simply push in and release. We push in and release. Well, how does that affect that? Well, basically what it's doing is it's causing a backup of blood from the carotid artery down into the heart itself by way of the aorta. We get some of that blood flow that backs up, and when blood flow backs up into the heart, the pressure goes up. When the pressure goes up, it puts pressure on the vagus nerve. This will occasionally work. It's not the best vagal maneuver to utilize, simply because it's limited as far as how much pressure it will put on the vagus nerve. Plus, it comes with a pretty concerning caveat or side effect. Remember, as we get older, we begin to develop plaque in our arteries. We're mostly concerned about our heart as well as within our brain, but we get plaque everywhere in every one of the arteries. If we push on the carotid arteries and we break that plaque off, guess where its next stop is going to be? Somewhere in the brain. And if it gets into an artery that's smaller than the plaque, now we come up with an ischemic stroke. So how do we minimize that? Remember, I said to minimize, not eliminate. So how do we minimize that? Well, we take our stethoscope, we put it on the carotid artery that we're going to listen to. And if it has a fairly free, or if it only has minimal plaque that is there, you will hear a nice sounding pulse, basically a whoosh, whoosh, whoosh sound as the blood is flowing through the carotid arteries. However, if you hear a bruit, and that's spelled B-R-U-I-T, bruit, B-R-U-I-T, you'll hear a whoosh, whoosh. And basically what's happened here is that the plaque is built up enough that it is causing a disturbance in the flow of not the force, but of the blood that's going through the carotid arteries. If we hear that, we do not do carotid massage on that artery. Now, my question here is, and I'll throw this one out to John. If we hear a bruit on the, say, the right side of the carotid artery, do we go over and check the left side? And if we don't hear a bruit, do we do carotid massage there, John?
No, because I assume if you don't hear it on one side, there's still gonna be brain tissue that's not being oxygenated the way it should be. So I assume that you'd either do it on, I assume you just do it on both sides.
So again, if I understood what you're saying, you are correct. Here's the thing. Now remember, typically, again, I shared with you that we develop plaque throughout the entire body. Okay, so we're going to have this plaque that's going everywhere. So if we hear a bruit over on, I guess this is my right, on the right side, we can come over here and we can listen to the left. And technically, if you don't hear a bruit, you would be okay in doing carotid massage. I'm going to advise against it, and I think most of the research holds this out, simply because if there's blockage in one side, there's probably going to be blockage in the other. And we've got more effective methods that we can go to. A lot of people, when they are starting out with doing vagal maneuvers, they just simply skip this one completely and totally. And you would be perfectly okay to do this as well. You just need to be familiar with what it is. So now, again, as we are looking at this, we increase the pressure within the chest to activate the sympathetic nervous system, to slow the heart rate down. And that's the key that we're looking at. Within this pressure, and it typically is working within the atria generally, and the SA nodes specifically, what it does is it slows down the conduction velocity coming out of the atria or the SA node. And then it also helps to slow the passage through at the AV node. Now, somebody remind me, what happens to our electricity when it hits the AV node?
It pauses for, well, it gets held back so both the atria and the ventricles can contract, like not simultaneously, but back and forth.
That's perfect. You're exactly right. So as we're coming through here, we're going to lengthen out that pause. Now, remember, I guess you could technically say we're instilling a type of AV block for the good of a cause. But we're not blocking it. We're just wanting it to be held up there just a little bit longer. Because remember, if we slow down inotropy of a patient that has a really fast heart rate, now what we're going to do is that we're also going to slow down chronotropy, leading to increased preload. Kira's got a really, really good question in here, and it says, what's the most effective vagal maneuver? So I would tell you, Kira, the most effective that I have found is one of two things. Number one is that if you will take like an oxygen cannula, many times people will say, or textbooks will say, have your patient blow through a straw. I don't know about you, but on my ambulance checkoff list, there was nothing titled emergency straws. But what we do have is that we have oxygen tubing. We also have syringes. And so, Kira, what I would do in this situation with this particular vagal maneuver is what we're looking at being what I think is the most effective, would be to, first of all, have your patient try to either blow through an oxygen tubing that is probably about 8 to 10 inches long. They're going to feel and hear some of that air coming through, so they're going to have kind of an incentive to get that through. Or the other thing is that you can get a syringe of 3 millimeters or larger, pull it back just a little way, and obviously your patient's not going to be able to blow the plunger out, but what you want to do is you want them to put their mouth around the end where the medicine would come out. Please don't have a needle on there. That's a whole lot of paperwork. But you would just simply have them blow into the syringe, imagining that they're trying to push that plunger out, and that increases the pressure inside the chest. The other type that is a really, really effective type of vagal maneuver is to simply tell your patient, okay, I want you to bear down with, I want you to take a deep breath, hold your breath, and bear down like you're really constipated and you're trying to take a bowel movement, okay? That increases pressure within the chest as well. Understand, and I don't say this to be disrespectful, it's kind of funny, but hey, this is EMS. If you're dealing with older patients, be prepared that they might indeed have a bowel movement. So you want to kind of keep that in mind if you're utilizing that. So that would be, those would be the two that I think are the most effective. We're going to talk about another one here that we're generally not ever going to use with adults, but we would potentially use for infants and very young children in just a minute. And that involves ice water. Hopefully that helps, Kara. Good question. So again, what this does is it just simply puts pressure on the vagus nerve, and it increases the blood pressure, and hopefully it will decrease the heart rate. This blowing out, this pressure that they're trying to get out, needs to occur for about 10 to 15 seconds per interval. And it may take several times for this to come in, if it's going to be effective, for it to work. The challenge is going to be here, ladies and gentlemen, is if your patient is already dyspneic, they're probably not going to be able to do this, which would mean now we want to look at, as we'll talk about in a minute, either medication or moving on up into addressing this with electricity. Now, Kara, here's the one that I was telling you about that is a little bit different. One of the things that we can do with young children, and I'll be very honest with you, I've never ever had to use this method before, is that we would have them put their face down into a container of ice cold water. There's a couple of things that happen here, okay? When you're dealing with really young children, they may not understand the concept of blowing through a straw, an O2 line, or a plunger. They're probably definitely not going to be able to understand the concept, especially for infants, of bearing down against a closed glottis. So in this situation, we would put their face down into ice cold water. Why does this work? Two reasons. Number one is that even kids, this is why infants 6 months old and older, they can become swimmers really, really quickly, more so than we can as adults, because when they go underwater, they know, oh, I got to hold my breath. Okay, so it's just a natural response that's designed within their brain. So what do? They take a deep breath, they hold it, pressure increases in the chest, puts pressure on the vagus nerve. Hopefully, it slows the heart rate down. Second thing, remember, the body has what's called a mammalian diving reflex. In cold water drownings, it slows down the metabolism. It slows down respiratory rate. It also slows down the heart rate automatically. So if we have a small child that does not understand the concept of being able to do vagal maneuvers, we would simply put their face down periodically. Don't hold it down there forever. That's, again, a lot more paperwork. But we would put their face down into ice cold water and raise it back up. Now, let me give you a warning here. You got to tell the parents, and especially the moms take good care of their kids, as to what you're doing and why you are doing it. Otherwise, you're going to be in a world of trouble if you just kind of pop this out on everybody. All right. So it can be very effective, and but you got to make sure that everybody does that. Richard says, would this also work on adult patients? Yeah, the premise is still there, Richard, as far as adults going. But this is kind of elaborate. And again, we're going to have to be in a residence of where we would have access to, or into like a restaurant or someplace that we're going to have access to ice water. And typically what we would do with adults is that we would have them do the other vagal maneuvers, just primarily because of the simplicity of doing that. Most of the time, we're going to use the face in ice water for kids just simply because they don't understand the concept. All right, good question. So as we're going through here, again, carotid massage, put your patient in a supine position, push in for about 10 seconds, and then relax. Don't do any of this until you listen to both carotid arteries for the possibility of a breathe. Okay. Here's the other thing that would make this a contraindication for your patient is that if your patient has had a stroke of either ischemic or hemorrhagic within the last 3 months, then this eliminates that for them. Carotid massage will not work in infants and very young children. Why? This is your all's time. Okay, let's see. Somebody's chatting.
The carotid massage wouldn't work in infants because
Think anatomy.
you're going to cut that oxygenation off too much. They have a thin neck, a small neck. I mean, it'd be the same reason why we check the brachial artery for a pulse on infants instead of the carotid.
All right, good, very good. So yeah, you're right. So infants don't, and I may be misunderstanding there, Yusuf, and if I am, I apologize. They don't really have a thin neck. They have a great big fat neck, and that's part of the anatomy. Keep in mind that infants in particular are born with lots of baby fat, especially just kind of remember for coming attractions, babies have a lot of brown fat, which is pretty much useless as far as insulation. That changes as they get older. But when you go in to push, two things that work against this is number one, they have lots of fat in their neck, not a lot of muscle. So you don't really have anything solid to push against. Second thing is the carotid artery in the infant is really, really small. So, and because of the adipose tissue that surrounds it, it's most likely not going to put any pressure on that. So that's what I was thinking about. Oh, that's okay. That's all right. Toddler, yeah. So as they begin to progress into toddler age, now they begin, obviously they have much more neck muscle control. The problem is going to be their ability to cognitively understand what you're wanting them to do as far as breathing. Mark says, what percent of the time do each of these methods work in practice, vagal, adenosine, and then cardioversion? I don't know, Mark. I do know that vagal maneuvers will often be really, really effective early on in patients with early onset. I would tell you that vagal maneuvers are not really effective if the precipitating cause of the SVT is medication or drug related. So, if your patient is having, lots of energy drinks, maybe they've had too much caffeine, maybe they're taking a medication that would speed up, like diet pills. In the past, those were basically speed and they would speed everything up. The vagal maneuvers are not going to be very effective on those. Why? Because it is a chemical process that is inducing this. So then you would move potentially on into the medication and or electricity. And speaking of a medication, here we go. If vagal maneuvers don't work, we're going to treat this with adenosine. Adenosine gets chewed up. It gets metabolized really, really quickly as soon as it enters the vascular system that you give it. So we got to give this through a large vein as close to the heart as we possibly can. And we've got to be able to push it really, really quick, followed up by a bolus. Now, our initial dose, and we can give 2 doses of adenosine. Initial dose is going to be 6 milligrams. If that first dose does not work, now we can double it up to 12 milligrams. Once we get to 12 milligrams, if it doesn't work, our only option is left is now to go with electricity. Here's one of the things, or several things I want to stress. Number one, get your line started in the largest antecubital that you can find. Okay. Ideally, if I were the one that would make the rules, I would tell you for your symptomatic patients that you're starting with adenosine, I would tell you to start with an external jugular vein, because now you're only about 4 to 6 inches away from the heart itself. Probably not the best thing to do for your patients that are awake and alert, to approach them with a needle going into their neck. So get the largest vein that you can start. If you can get a 16, I rarely recommend that you would use a 16 on your cardiac patients. In this one, I would tell you, if you can get a 16 in your patient, if their vasculature allows that, then definitely go for a 16. The other thing that you want to do is you want to use a short catheter, not a long one, okay? Because it just kind of, the longer the catheter, the more the friction that is there. And you're thinking, well, it's only going to be a few microseconds. But understand that the half-life of adenosine is about 10 seconds. And so everything that we can do to speed up that process of getting it into the system and getting it to the heart is going to help. Once you've got that started and you know that it's free flowing, once you give your adenosine, then you would follow it with a flush of 10 to 20 milliliters of normal saline. This, to be done effectively, is a 2-person operation. One person cannot do this as effective as if you got 2 people. Couple of ways of doing this is that you can come in and put in a 3-way stopcock. It's a little piece of plastic that goes in between your extension and your IV tubing, and basically it is a valve. We turn it over to the left side, we can push the adenosine. We turn it over to the right, and we have another syringe with 10 to 20 milliliters of normal saline that are on there, and we can push that. That's one way to do it. Another way to do it, which to me is just as effective and doesn't require as much finesse or a skill of being able to use a 3-way stopcock, is to use the medic getting ready to push it in. And again, we're going to use the injection site that is the closest to our patient. Your partner, which could be an EMT, there's absolutely nothing wrong with your EMT to do this, would be up with the bag, squeezing the bag as soon as you start giving it. So rather than pushing it, and now we've got the flush, we got the flush going at the exact same time. That's another way, and that's actually my preference. That's just Bill's preference. One is not better than the other. Bella asked, how long would you wait to give the second dose if the first one doesn't work, since the half-life is so short? Like I've said about you guys before, I love being around smart people. These are smart people questions. Generally, what I would tell you to do is you would wait about 1 to 2 minutes. After a minute, for all means and purposes, the adenosine is going to be out of the system because of such short half-life. Again, then you would come in with the double dose and going straight into there. Now, let me ask you guys a question. If you give the first dose of adenosine and it doesn't work, and now your patient is worse, are you locked into going with the second dose of adenosine before you could progress into cardioversion? And defend your answer when you give it.
I would say no, but I think it's probably better to finish off your dosage regimen before moving on to a different treatment. But in real life, if they've gotten worse and depending on how bad they have gotten, I might just skip prepping another dose of adenosine just to get the synchronized cardioversion going, treat them. You don't want to really delay the synchronized cardioversion for medication treatment in real world, I think.
Okay. Thank you, Yusuf. Anybody else? Well, bring my class back. You guys talk more than this.
I agree with Yusuf. I think it just like kind of depends on the patient's presentation and how quickly they're diminishing. Like if you are able to like do that second dose without any like serious consequences, like from waiting to give electricity, then I say go ahead. But if there are going to be serious ones, then I say just go ahead and skip it.
Yeah, both you folks are right. So again, what we would look at here is that like most medicine, the answer always starts out with, well, it depends. If you can give that second dose without delaying your defibrillation, or I'm sorry, not your defibrillation, your cardioversion, then go ahead and give it. If for some reason your patient is just really crashing and there's really no reason why you can't go ahead and put the pads on your patient if you so desire. I would tell you, if your patient is stable, don't put the pads on for a couple of reasons. One, the pads are usually about $45, $50, and it raises the anxiety of the patient because they've seen enough medical movies, medical shows to know what those pads mean. And so as you're going through here, the big thing to keep in mind is get the treatment going to them as quickly as you can. Now, some of the things to remember about adenosine is that it will cause all kinds of weird stuff, in particular, asystole. So you could potentially have a run of asystole that is at least 6 to maybe even 12 seconds long that persists in or that results in your patient having chest pain, becoming diaphoretic. Quite often, patients will become flushed. They'll feel like that they've had a hot flash from the top of their head down to the soles of their feet. So before you give adenosine, just tell your patient, especially if they've never had it before. If they've had it before, they know what's coming. And sometimes they'll refuse it. But if you're giving adenosine to a patient and they've never had it before, just tell the patient you're not going to feel good. You're probably going to have some chest pain. You're going to feel maybe a little nauseated, get really hot. But these are all going to go away in less than a minute. The next thing I think I've shared with you is turn the monitor away from the patient to where they can't see it. Again, they've watched medical shows on television, and turn your little beep, beep, beep off. They also know what that means. And then you can start that back up once you've run the course of giving your adenosine. So that's just kind of some of the things that will help to reduce the anxiety of your patient. If your patient is taking a medicine known as carbamazepine, which is Tegretol, it's a type of anti-seizure medicine. It's a really, really old medicine. Or if they're taking dipropamol, it's hard to say, dipropamol, which is a type of blood thinner, and I'll get these out to you as far as the spelling. You want to reduce that amount to half. So we would give 3 for the first dose, and we would give 6 for the second one. This is also going to be true if your patient is a heart transplant. So we want to reduce the dose that we're going to give them. Keep in mind 2 other things. Number 1, adenosine. If your patient has asthma, it can cause bronchospasm. So again, we might have to come back and treat that if it causes a bronchospasm. But again, like I've shared with you from day one, treat what's going to kill your patient first. Also, if your patient's SVT is coming about because they've been binging on caffeine, you may actually have to give higher doses. So you may start with 12 and then give 12 or then even 18, depending upon how much you carry. I would encourage you not to go with higher doses in these situations. Again, high caffeine content, because caffeine kind of works like Narcan does for an opioid. It works that way towards adenosine, is that it speeds up its metabolism so that it's not nearly as effective. Make sure you do a consult with med control before you would do that. Another med that you can give for these patients, if you wanted to, would be to give them diltiazem. Diltiazem is a calcium channel blocker. Remember, what we're wanting to do is we're wanting to slow down the mechanical and the electrical action. So we're wanting to slow down inotropy, and we're wanting to slow down dromotropy. A calcium blocker can do that, and it slows it down. Your dosing for cardizem, and you may see this on an exam, would be typically about 0.25 milligrams per kilogram as far as a loading dose to get it up to a certain level. And then we're going to follow that up with a 5 to 15 milligram per hour infusion. Okay. Now, when we're going to cardiovert our patient, now we have.
Can I see that slide again for a second?
Oh, absolutely. There you go.
I'll just take a picture of it. That's all I need.
Okay. If we're going to go with cardioversion, now you've got another question you got to ask. Is my patient so unstable that I don't have time to give him or her any sedation, or can I give them something that they're not going to remember what I'm about to do to them? So you want to think about potentially some type of a benzo. Now, again, just as kind of a brief reminder and review, benzos enhance the effect of GABA, G-A-B-A. GABA is the area of the brain, well, it produces GABA, and that helps us to relax, to calm down. And a benzo acts at the limbic and the hypothalamic regions of the brain, and it can bring about CNS depression, which includes sedation, which is what we would want for this particular patient. We use benzos to help patients that are having seizures, but we also use benzos to help people to relax and not to remember. Generally, what you would want to keep in mind here is, again, like narcotics, benzos can cause respiratory depression. How do we minimize that? Two ways. Number one, we start with the lowest appropriate dose, and we always give a benzo, like we talked about, we always give a benzo really, really slow. We don't give it fast. Even if you give the appropriate dose and you slam it in there, there's a possibility that your patient is going to have some type of an apneic period. So it's not going to work out well for them if you give it really fast. Generally, what we're looking at here is you can still go with the old standby of Valium, diazepam. And so your dosing range generally would be, if you want moderate sedation, you can give them 2 to 5 milligrams slow IV push. You can indeed give it IM, but it's going to take considerably longer for it to begin to work, especially if your patient is large. If you want a deeper sedation, then you can go up to 5 to 10 milligrams, slow IV push, probably no faster than 5 milligrams a minute. And even if you're giving 2 milligrams, I would still set that 1 minute dosing time as what your regimen is going to be. So hopefully to help to minimize any problem with with respiratory depression. You can also give midazolam, which is the trade name is called Versed. You have the same actions as Valium, same dosing regimen, and the same adverse reactions because they're both benzos. Now, keep in mind that some of your patients will require very, very little of a benzo for them to go off into la la land. Okay. These are typically people who don't take a lot of pain medicine, who are not utilizing cannabis or alcohol or any other type of recreational drug, whether it is an opioid or if it's an amphetamine. If you've got a person that falls into one or more of those categories, now you're probably going to have to give a higher dose for them to be able to be sedated. Now, what are we looking at here as far as your cardioversion? All right. Let me see what question here. Hold just a second. No problem. Okay. So what we're looking at here is when you're getting ready to cardiovert, the key thing here is, first of all, make sure that your defib pads or your electrical pads, let's call them that, have good pad to skin contact. So you're going to want to put them on. You're going to put a little bit of pressure on them so that they've got good contact. You can go to right shoulder to left lower area or sternum like that, or you can go anterior posterior. There are some studies that show that the interior posterior, putting it on the front and directly on the back for either defibrillation or cardioversion, does seem to provide better results. The downside of that is we can run into some problems if we wind up doing CPR of breaking down the pad as a result of the putting pressure on that. Make sure that if you've sedated your patients, you try to sedate them to the appropriate level. This does not mean that your patient will go to sleep. The big thing that we want to remember is, do they, are we going to help to reduce the pain, and are we going to be able to induce a hypnotic state so that they're not going to remember it, okay? Again, here's the thing, and this is the hard part of medicine. Sometimes you're going to be in a situation where you're going to say, my patient's still alert. My patient's about to die. I don't have time to give a benzo, or my vital signs are already so bad that if I give a benzo, it's only going to make them worse. And unfortunately, that's one of those situations where you're going to have to do what I say, ask for forgiveness rather than permission, and go ahead and cardiovert them without any medicine. All right. Now, I'm going to try to share a video with you. If the audio does not come across, somebody let me know, and I will put the link on Blackboard. I would really like you to watch this. This is a video given by his permission of a national firefighter about 10 years ago that had a problem with SVT. And he gave permission for his partner to videotape and share the whole process. So tell me if you're able, you'll be able to see the video. I don't know if Zoom will let me share the audio. Hold on here.
How are you doing, man? Are you with us? Okay.
Can y'all hear that?
Yes, we can.
Awesome. Okay. This is a cool video.
How are you doing? Still with us a little?
Listen to the beep in the back.
How are you doing, man? Johnny.
There is a little profanity here at the end, by the way.
All done.
Johnny, how do you feel?
Relax. See if he's not focused. Afraid sedate. How many joules was that? 200.
200. 200. All right. Let me see if I can get back to my slide here now. All right. Expand the question to a lack of pain management in general. Go ahead. Mark, tell me more about what you're meaning there, and I'll be happy to do that.
Into the question above mine.
Say it again.
I'm talking about the question above mine.
Oh, the
In the chat.
question above yours. Hold on. Let me get there. Would we be subject to litigation or discipline if we perform synchronized cardioversion without pain management or sedation? Good question. This is a thing in medicine you always have in the back of your mind. If you are always acting in the best interest of your patient, you will be protected. Now, understand, again, you can be called to a lawsuit for any reason. Some of them are really pretty stupid. But generally what would happen is that if you have good documentation that says my patient's blood pressure was 70/20, they were semi-responsive, their heart rate was 180, I did not have time to even get my line started in that situation, because now they are right there between the point of decompensated shock and irreversible shock, then you would indeed be protected in that situation. Does that help? All right, let's transition from SVT to VTAC. VTAC is a wide complex, which means greater than 120 milliseconds. 120 milliseconds, 3 small boxes that are a heart rate of greater than 100. Now, you can have slow VTAC, you can have fast VTAC. What we're talking about in here, ladies and gentlemen, is VTAC with a pulse. We'll talk about VTAC without a pulse a little bit later on. Now, when we're looking at this, you can have short runs, or you can have long runs, or you can have sustained VTAC, which is a short run would be 3 beats and then it stops. Okay. A long run would be anywhere from, say, like 10 beats. So a short run would be 3 to 10, anything from 10 on up to say 100 of the VTAC itself would be a long run, and then just straight VTAC that you would see would be considered a sustained. Now, here's the thing to remember. If your VTAC lasts longer than 30 seconds, our patient's blood pressure is going to be ready to plummet. They're going to begin going into shock. They're not going to do well. We further classify, as you learned in 303, we have monomorphic and polymorphic based on what it looks like. The top one is a monomorphic VTAC. The second one down at the bottom is a polymorphic VTAC, commonly known as torsades. Now, torsades is a little bit different as far as how it is treated as opposed to monomorphic VTAC. The most common cause of VTAC in humans today is going to be ischemic heart disease. Now, we can have other issues that come into play. So, for example, you may have, again, we've already talked about this in class, the young lady with charged lemonade from Panera. She had a history of long QT syndrome. And so people who have that are at a greater risk of VTAC. People that have low potassium or low calcium, or in particular, low magnesium, are at a greater risk. People who use and abuse methamphetamines are at a greater risk for VTAC as well. Again, these are all some of the risk factors that you're going to see with these particular patients. Generally, the thing that we're really concerned about with patients that have VTAC is that if we do not address it, it can and often will deteriorate into ventricular fibrillation. The thing we got to remember is that our patients are at a higher risk for VTAC with or without a pulse that can lead into death for the 48 hours after they have an MI. That's typically why when they take a patient into the hospital, even if they take them into the cath lab and they do a heart cath and everything comes out okay, then they're not going to let them go home for about 48 hours just to watch them. When a patient has an MI, again, this kind of comes back to that cellular level. As those myocardial cells die off, they rupture, and now we get a bunch of potassium that comes out around and is floating in the body. This can trigger spontaneous ventricular tachycardia. This is why the patients will spend that 48 hours in the hospital. Getting a really good history and physical on your patient is critical. Many times, if not most, your patients will be older than 65 years of age and have a history of cardiac disease, including heart failure, MI, angina, any type of ischemic. It gives you a greater indication of about 10%. Don't worry about the number, but just understand they have a greater percentage of being able to have VTAC as far as people that don't. Now, we can indeed have patients who have non-sustained VTAC, short runs of VTAC, that basically we just watch. We watch really, really closely. In those patients, I would tell you, don't put the pads on. They're not ready for them yet. If we've got stable patients that you feel like need to be converted from that VTAC with a pulse, we're going to use amiodarone. Okay. Now we can use another drug called procainamide, but we're going to focus in on amiodarone first as far as going in through this. Procainamide does work, and it will slow down VTAC if it doesn't terminate it. All right. Now, I want to get on over here to the amiodarone treatment because I think that's going to be the route that we're going to go with first. We'll come back and pick up procainamide primarily during your ACLS. So amiodarone converts about a third of patients that have, and I'm watching my time here close as well, of patients that convert to sinus rhythm. But the nice thing about amiodarone is it does really, really well about keeping the patients from coming back into VTAC. The way that it does this is it blocks the potassium channels that are responsible for repolarization. It increases that absolute refractory period that makes it less likely that you're going to have a potential R on T, and it raises the level of difficulty for our patients that are going to be having PVCs that can have an increased rate on our R on Ts. Contraindications for this include patients who are in cardiogenic shock, leading to with their lowered in their blood pressure. If they have a slow heart rate, obviously we don't want to slow down a slow heart rate, or patients that have congestive heart failure. We want to kind of watch that really closely. Here's your cardiac arrest dose. So if your patient is in arrest, we're going to give our patient 300 milligrams IV push. And then if we need to, we'll repeat it in at half that dose, 150 milligrams, in about 10 minutes. What we're going to do with our patients that have symptomatic VTAC or symptomatic PVCs, patient is weak, their pressure is down because they're having multiple PVCs, especially if these PVCs are ectopic what we want to do is we'll start them out with 150 milligrams, and we're going to give that over 10 minutes. The simplest way to do that is to pull up 150 milligrams of amiodarone, inject it into an IV bag of normal saline, 100 milliliters, and then do the calculation to flow that or set it up to your pump to flow that in through over 10 minutes. Once we've done that, then we also want to set up an infusion so that we are giving them 1 milligram per minute for the next 6 hours. Many times that infusion will come once we get to the hospital, but that infusion rate is what you would definitely need to know for your ACLS. And you can find this information to go back and review it, either watching the video or within your ACLS Pocket Guide. What I've got left here is a case study, but I've got about 3 minutes. And so we are going to stop there. I'm going to stop